Sir, no videos is seen, so I think it may take a few seconds, no, to start the YouTube live. So I think we will wait for some time when it starts. So far, no videos has been seen.
Okay, sir.
Did you log in from our YouTube channel
Yes, I have.
and you went to the YouTube live option, right,
Yes,
sir?
yes. Please check now. It is coming.
Ah, yes, yes. Yeah, now it is coming. Yeah,
Yeah, finally.
yes, sir. So I think it will be continuing now till evening. Log in from our YouTube channel.
Yes, I have.
Okay, sir. Okay, sir. Thank you. Thank you.
Taslim, please change your virtual background, no? Everybody, please put that
Please check.
virtual background.
I will start the Facebook live also. Once the discussion start, I will start the Facebook live too.
Okay.
Sandeep, you will be putting the bio slides, no? Workshop.
Yes, ma'am. I'll do that.
So what you do is that you can just start the workshop. You can just begin the workshop, and you can invite me, the chairperson of the workshop, project my bio slide. Then I will start talking. Is that fine?
Sure.
So you have to welcome the candidates on behalf of LGBTQ as an organizing committee. You have to welcome everybody.
Hello, Ranji ma'am. Your voice is not audible much.
Hello, am I audible?
It's okay, but still it's not clear as that of Sandeep.
Is it? Just a minute.
So how is it now? What is it?
Echo is coming, ma'am.
Yeah, it is loud enough now.
How is it now, Taslim?
Ma'am, it's fine. It's good. Here it is fine. Live it is fine. I don't know what about the YouTube live.
Taslim is telling about YouTube live about my
I
volume.
think so.
Okay.
सेंड कर दिया ना. हाँ, मैं बताऊंगा वर्चुअली.
Sandeep, it's 9:26. So shall I ask the participants to start login? Hello? Hello?
Ma'am, yes, ma'am, you can ask them. And
Okay.
ma'am, shall I make Taslim sir as co-host?
Yes, Taslim sir as co-host. Make me as co-host.
Sure.
Then Sandhya ma'am, Surbala.
Ma'am, shall we start admitting the people who are in waiting room or?
Whether Sandhya ma'am has joined or not, I'm not able to see.
Okay, we will wait then. No problem.
Lakshmi ma'am.
Yes, sir.
Lakshmi ma'am, just for a backup, if I have failed to project the bioslides of workshop people, can you do it?
Okay, sir. Okay, no problem.
So make
Okay,
Lakshmi
thank
as
you, ma'am.
also co-host.
I made already.
Okay, sir, no problem.
Lakshmi, why you have added two that CMC Vellore people bioslide? So I got confused. Are they going to announce?
Which ma'am?
Tara, Joy, and one more in that workshop bioslide, no?
Just let me check. Yes, they are the facilitators for the workshop, ma'am. Just told me.
Madam
Jeev
told.
Jeeva Christopher, ma'am, and Sarah Joy, ma'am.
So whether they will do the MC part, I really don't know.
I don't know. They are under facilitator heading, but with you people, not with the other facilitators.
Okay, okay. So they may be managing. I don't know. Anyway, let us
हाँ,
wait for madam.
okay, ma'am.
So मैम ज्वाइन करने के बाद ही हम सबको एडमिट करेंगे ना? We'll wait for Sandeep ma'am to join. Sandeep?
Yeah, yes, ma'am. Waiting for ma'am.
Hmm.
Ma'am, our cloud, the space is already full. What I'll do is that I'll record in the computer itself and I'll share the recordings later on. Is that okay?
Okay. Sandeep ma'am is telling allow them to join my PPT already with Sandeep. Ma'am's PPT you are having?
No, ma'am, I have to check once.
Today morning या yesterday night she has mailed my PPT करके. My PPT for workshop yesterday night. Sandeep, it is sent to your personal mail.
Okay, ma'am, check it.
I will send it once again. Did you receive Dr. Manoj's PPT? He didn't send the PPT, no?
No, ma'am.
Okay, I'll just ask Dr. Manoj to join.
Benju, ma'am. Sandeep, sir.
Yes.
It's just now I got mail from Sandhya, ma'am, and it said she mentioned that chairperson is you and co-chairperson Survala, ma'am. Experts are Mr. Francis Muthedan and Miss Jeeva Christopher. Okay. Soya ma'am's name is now removed. So kindly, Sandeep sir, kindly make a correction. Soya ma'am का PPT हटा दीजिएगा.
एक्सपर्ट है क्या जीवा क्रिस्टोफर?
Yes, उनके नाम के आगे मैम ने अभी एक्सपर्ट लिख दिया है.
अच्छा, मुझे नहीं पता था.
हाँ, मैंने अभी जस्ट चेक किया है, ये अभी अभी मेल किया है मैम ने.
Okay.
Then speakers are Manoj sir and Sandhya.
Okay.
Okay.
I think shall we add participants? What to do? Admit करे क्या?
7 8 9 1 0.
Good morning, ma'am.
Rooms I didn't do, ma'am. Live I am doing. Live.
संदीप, आपके जो बैकग्राउंड में जो एलजीबी का बोर्ड है ना, वो उल्टा दिख रहा है. इट इज जो बैकग्राउंड है ना आपका एलजीबी का बैकग्राउंड, जो नेम प्लेट है पीछे वाला, वो इट इज लुकिंग उल्टा. मतलब वी आर नॉट एबल टू रीड.
It's fine, ma'am.
No, now also it is Department of Psychiatric Nursing. It is पीछे का बैकग्राउंड.
Lakshmi ma'am, there's one correction you said. Whom I have to remove?
Jeeva Christopher ma'am is there, but earlier ma'am was also there, na?
Yeah.
Sarah.
Yeah. So I
Jeeva
just-
Christopher is the expert.
I just kept her slide, but with means one extra, so that I don't know in last moment if ma'am will say that her. So I'm not removing, but I'm adding one extra PPT, blank PPT.
Ma'am.
Not able to join.
Please, ma'am. Sorry, ma'am. So sorry. I'm looking into very other way. You're joined, ma'am. Okay. I'll admit. I'm admitting. I have admitted.
Are you admitting everybody?
No, I have Surbala ma'am called. She could
Okay.
not join.
संध्या मैम अब क्यों नहीं ज्वाइन कर रहे?
Morning.
Good morning. Surbala ma'am. Hello. Surbala ma'am, are you there? Hello.
Yeah, I'm here.
So I think I will do welcome, and then I will introduce Dr. Sandhya Gupta, Executive Chairperson. Then expert Dr. Manoj, I think you can invite.
Okay, so what I'm supposed to tell about him? Any CV or something? Bio slide is there, no?
Bio slide is there. Okay. So expert talk, Dr. Manoj. If madam is covering the overview with the PPT, then means then madam will not speak after Dr. Manoj.
Okay.
If she's giving overview without PPT, that means after Dr. Manoj, you have to again invite Madam Sandhya for her session. Then I will give I will announce the breakout rooms and other instructions.
Mhm.
Then you can initiate the group presentation. Then I can invite feedback from experts. Like that, we will do alternative way. Is that fine?
That's okay.
Okay.
There in this also.
Ma'am. Kunju ma'am came, ma'am.
No, it's coming.
There. If she's coming again, there will be a lot of confusion. Here means all people together, there will be echo, ma'am. All the devices together, if there are there.
She's attending.
Hello, ma'am. Good morning, ma'am.
the Zoom I have put for 2 p.m.
Pardon, ma'am?
Please send me the Zoom of this one.
Workshop.
LGB Zoom link, please send me.
Oh.
I'm not able to join.
Okay, I'll send, ma'am. Ma'am, send, ma'am.
I didn't call her, ma'am. I'll call.
Has Madam Sandhya joined?
No, ma'am, not yet. I'm waiting for her.
Hello, Sandeep sir. My video is not opening. Do you know how to correct it?
संदीप आपके बैकग्राउंड ब्लर मत करो प्लीज. आप बैकग्राउंड ब्लरिंग हटा दो. आप योर फेस इज नॉट विजिबल, नीदर आयरन मैम्स फेस. आप वो ब्लरिंग ऑफ बैकग्राउंड हटा दो प्लीज.
Sandeep sir, you can make the like background in the PPT which was shared. No, should I share you?
Yes.
इट इज ओके. वो LGB का है ना, सो दे आर द मेन ऑर्गेनाइजर्स ना. दिस आल्सो इज फाइन.
Okay, ma'am.
Hello. Hello. Am I audible?
Yes, sir.
Hello.
Audible.
My video is not opening. You know how to correct it?
So please check in the settings if there is an issue with the.
Actually, when I open the video, but nothing is seen in the screen. It's a blank one.
That is the problem.
And I think I tried to use the virtual background, but it's still loading. It shows it's still loading.
Maybe that's the issue, sir.
Then I'll try to leave the meeting and I'll come back. Okay.
Whether Dr. Francis sir has joined, Sandeep? Sandeep, you have muted. Francis sir has joined. Sandhya ma'am has joined or what?
Not joined. Sandhya ma'am is asking for password.
Where she's asking?
In group, workshop group.
Am I audible now, ma'am?
Yes. Passcode to ma'am. Passcode is 218461.
218,461, ma'am.
218461.
Yes.
Taslim has joined back or what?
Submitted. And then the madam has done.
Okay. So far, only 37 participants are in the waiting room.
Good morning.
Good morning, ma'am.
Dr. Manoj has joined. There is
Sandeep?
lot of problem in joining. I don't know. Sandeep, where are you? Hello.
Ma'am, good morning, ma'am.
Good morning. Please check what is the difficulty today. We are not able to join.
Good morning, ma'am.
Please check anybody in waiting room or something.
No, ma'am, everything is fine, ma'am. People are able to join.
I have taken half an hour to join. Please read messages in the group, Ranju. So many people are not able to join.
Sir, please join, sir. Hello, sir, please join.
मैंने आपको भेज दी है पीपीटी, आप एक बार चेक करेंगे जीमेल पर अपने?
हाँ, भेज देंगे सर, आप ज्वाइन कर लेना सर प्लीज, आई विल चेक.
हाँ, ऐसे ये वाली जो पीपीटी है ये कैसे प्ले होगी? मेरे को इसीलिए लग रहा था.
कौन सा जो वर्चुअल बैकग्राउंड?
नहीं, इसी जो मैंने ना आपको
Sandeep, I have sent you Dr. Manoj's PPT.
Okay, ma'am. Ma'am, you are sending in Gmail?
It's your Gmail.
Okay, ma'am. Okay.
Sandeep, Dr. Manoj wants you to handle PPT.
Ma'am?
Dr. Manoj के session का PPT please handle from your end.
Ma'am, I got it, ma'am. I got it.
Okay.
Yes.
Atul, please keep on admitting people. If you are failing to admit, no, please admit the
Yes, ma'am.
participants. Whether Dr. Manoj has joined, just tell me.
Good morning, everyone.
Good morning, ma'am. Good morning, ma'am.
Good
I
morning.
welcome everybody to this morning session.
Good morning, ma'am.
Can we have video on for a few minutes? Can we have all videos on for a few seconds for the purpose of recording? Can we request everybody to please open your video for a few minutes? Then we can have a nice picture of all of you. I request everybody to open the video for a few minutes. And after that also, if you like, you can keep it on. But at the moment, we are requesting you for a nice picture of the group. Dr. Surbala, can you communicate with the delegates once again? Those who have not joined, please hurry up in joining.
No, ma'am, yesterday only I had put the message. After that, I have not shared any message in the group.
Dr. Surbala, please put the passcode there again and again, because it took very long time for me to join. So they are asking passcode again and again. Okay, let us start when the time is there. Please start, Ranju.
As part of third international virtual on partnership and collaboration work in managing addictive behavior disorder and substance use disorders.
We
We are
can't hear you. I don't know. We can't hear you.
Hello, am I
Here,
audible?
we can't hear you.
Hello, am I audible?
Very
Yes
little.
to us. Yes to us.
Yes, ma'am.
Now it is little better.
Okay, so very good morning to one and all. As part of third International Virtual Nursing Conference on partnership and collaboration work in managing addictive behavioral disorders and substance use disorder, we are going to start the pre-conference workshop on collaboration in managing substance use disorder nurses role. First of all, let me thank this opportunity for giving this opportunity as chairperson. So let me thank the organizers. The main organizers of this conference is LGBRIMH Tezpur, Assam, Arizona Indian Nurses Association, USA, and ABD&SUD-CARE Group, India. So let me welcome the executive chairperson, Dr. Sandhya Gupta, to this conference. Welcome, ma'am. Let me welcome the experts of today. Dr. Manoj Kumar, Assistant Professor, Department of Psychiatry, IBHAS. Welcome, sir. Let me welcome the expert, Mr. Francis Muthaden, who is the Project Director and Chief Trainer of MOIC Medical College Hospital. Welcome you, sir. I welcome Dr. Jeeva Christopher from CMC Vellore to this workshop. I welcome co-chairperson Dr. Yumnam Surbala Devi, Associate Professor, AIMS, New Delhi, College of Nursing, to this workshop.
Please move the slides. Slides are not at all moving.
I welcome all the facilitators of the pre-conference workshop to this workshop, and now I welcome all the delegates of this workshop. So we'll be beginning this workshop. So let me invite Dr. Sandhya Gupta, Executive Chairperson, to give the overview about this pre-conference workshop. Over to you, ma'am. Thank you.
Thank you very much, Dr. Ranju. I request Mr. Sandeep to kindly share my slides. You have it, Sandeep?
Yes, ma'am. Just a minute, ma'am. I'm sharing.
So let us think about how a journey of a person who got stuck with the problem of dependence begins, and how we can help this person to walk in that journey. Can we manage to help this person on one-on-one in a OPD clinic or in an outpatient department? Yes, we can do that. Admit the patient for 15 days, and we can do whatever to take care of the withdrawal symptoms. And patient will be fine after 10 days, 15 days, or maybe 1 month. After that, we forget about the patient. Patient and the family, they have to look after themselves. What is the danger here? All of us know the danger is relapse. It's a chronic relapsing disorder. So if we do not understand that this particular disorder can relapse naturally, you don't have to put any effort to relapse here. It's not a mosquito bite that you will have another episode when you have a mosquito, when you get exposed to virus or when you get exposed to bacteria. No, because the trigger lies within you. So the trigger is sitting inside you. You can relapse anytime. So can we just manage with one-on-one treatment in clinic or in hospital? Answer is no. So here we are having a next slide, please, Sandeep. So here we are having next slide, opportunity to focus all of us, how the whole community, how the whole family can participate in the treatment, in the recovery. Actually, we call it a recovery. So without collaborating, not only with different types of health professionals, but with different types of genre, different type of people around us, who can help us in which way? Next, please, Sandeep. Everybody can contribute. Most of the time we think the patient has come to me, patient belongs to me, I have to do everything. Not at all true. We have different type of people in health sector, different type of services in health sector. Therefore, make use of all the people who are skilled in different aspects. As you can see, we have special people dealing with addiction only. We have psychologists, we have social workers, we have nurses, we have pharmacists. Everybody has to participate at their level. But how to make sure that the patient gets the benefit of all this? Next, how will the patient reach them? We need to have networking, we need to have family. Now we have other stakeholders. We can give treatment for 15 days, but after that, what happens? The family members have to help the person. Peer recovery support specialists are there. They prepare the peer how to help. Go to the previous one, Sandeep. Then there are a lot of non-government organizations, philanthropists who have developed some programs for local community. Then we have certain support groups through the church, like Alcoholic Anonymous, etc. Then without legal agencies, we cannot proceed because our clients can get into legal trouble anytime. So there are counselors in the legal system to deal with these things. Then of course, all educational institutions have to participate, especially in prevention and identification. Next. Next, Sandeep. So, hello Sandeep, next please. It's not moving. LGB has logged out. Okay, never mind. So as you can see that there are so many stakeholders around us who can help us in many ways. And we are now presenting you the models, some of the frameworks where we can involve different type of people, different type of agencies, and different type of timings. At different timings, different people can help us. Some people can help us in reaching the help. Some people can help us in maintaining motivation. Some people can help us in improving our day-to-day life. Some people can help us in preventing relapse. So different people are helping differently at different times. So how do we make a framework for the patient so he can make use of that? Next, please, can we go to the slides? Next slide. Are you able to move the slides, Sandeep? So
Slides
what
are
is the
visible, ma'am?
importance? Holistic patient care, that means not only from medical treatment point of view, we have lost this person from mainstream. So how to bring this person back to mainstream? This person has lost his physical health also. How to bring him back to that? This person has lost social system, has lost maybe the family relationships. How to bring him back? Then resource optimization. We have many people suffering from problem, but resources are less. So how to make use of resources in a most judicial manner? Next. Next, please. Next, please.
Just give a minute, ma'am. There's some issue with the slides.
So as you can see, we have lots of disciplines which are not knowing about each other. I do not know about other fields. So respecting each other's training, respecting each other's skills is very important. Then technology has become very important. As you can see, we are all ready with technology, but anytime anything can happen. So a lot of training, lot of things are required for us to learn again and again. Then if we don't evaluate, we will not be able to move forward. We will be getting stuck with the different type of things. Can we go to next slide, please? Yeah, just go next. So it will become definitely when so many people are trying to help at different stages of recovery, it will bring different type of benefit. Of course, the most important thing for us is to keep the patient in the treatment line. As it is a relapsing chronic disorder, patient has to remain in contact with the treating team, initially very frequently, and later on maybe once in 6 months, and later on maybe once in 2 years. It depends, because any relapsing disorder, the contact with the treatment service center is very, very essential. And then of course recovery outcome become better when so many people are participating at different stages. Then patient will definitely feel better because he is able to contribute more, he becomes more responsible person. Next slide, please. But there are challenges, definitely. There will be difficulty in communication with so many type of people, so many type of agencies. There is stigma. We don't want anybody to know that I have this problem. My family doesn't want anybody to know that my child is having a problem. So I'm scared. I have stigma. I cannot take help because then everybody comes to know. So overcoming stigma is a very big challenge, but there are solutions. We are going to talk about that. Next. Next, please. Next.
हाँ मी
Next.
व्यू प्रोफाइल क्या बैकग्राउंड बोल के वर्चुअल बैकग्राउंड
Next. Next, please. Yeah. So as we can see, I have brought in one sample here where so many people are presenting their success story on if they are doing intervention with collaboration of many people, how it has been successful. Next, please. We can share these links with you later. You can see it later. So I would now request the next speaker, Dr. Manoj, who is Assistant Professor at ABD&SUD, New Delhi, to continue. Because of the time frame is less, I will just move forward and I request Dr. Manoj to take over. Thank you.
Thank you, ma'am, for the brief overview regarding this conference workshop. So can I have the bio slide of Dr. Manoj, please?
Dr. Manoj, will you please share yourself, your slides? Or Ranju, you like to share?
Yeah, to introduce our next speaker, I would like to introduce Dr. Manoj Kumar. Sir is the assistant professor in the ABD&SUD, New Delhi. And Sir, Dr. Manoj has got lots of achievement and awards. Dr. Manoj has more than 12 publications in the international journal. And he has got the certificate of the appreciation, and he's the chief secretary of the Delhi in 2019. And he's also awarded with the Corona Warrior by Deputy Chief Minister by Delhi 2022. And Dr. Manoj has 22 years of experience in the field of psychiatry. An area of interest is adult psychiatry, addiction, and forensic psychiatry. So Dr. Manoj Kumar is right now heading the unit of addiction psychiatry in the ABD&SUD. So it is really good for us to have you here in the pre-conference workshop, sir. So please continue with your session, sir. Over to you.
Is the slide visible?
Please bring in presentation mode.
Ma'am, is the presentation mode
No,
visible?
no,
Now?
it's not. It's not.
Okay, then I think there is some issue with my laptop. Sandeep, will you be able to share it?
Ma'am, just give me a few minutes, ma'am. Couple of minutes. I'm sure. Ma'am, is the screen visible?
Yes, yes.
Yes, it's fine.
Dr. Manoj.
Manoj sir, are you able to speak?
Dr. Manoj?
So you're not audible.
Dr. Manoj, if you can hear us, please leave and join again. I think there is some issue there. Because he's already co-host.
But he can join from other device if there is any problem.
Please join from different device if you can. Please phone him. Meanwhile, I would like to say to all of you that it becomes very easy for all of us to start something new, to try something new. And when there is something that we like, we have a right to continue to take it again. If we feel good, we can take it again. So all of us have the right to feel good. And that is the reason that our physiology is helping in tolerance, physiology is helping independence, tolerance is helping us to increase the dose. The tolerance sitting in our physiology is responsible that we can't help it. So it is important to understand the phenomena that it's going to be a chronic problem, and the family has to understand it's a chronic disorder. So therefore, it is like you have joined a school. When you go for addiction, it is something like you have joined a school. Unless and until you finish 12 years of schooling, you should not leave the school. So it's like enrolling in a school. So there are people in the school who help us at different stages to move from one step to another step. And then we graduate from the school. So taking treatment for addiction is something like that. So you are always in touch with your helpers and with your counselors and with your educators. So they make you feel better, not only from treatment point of view, but also in personality wise, your social system and your grooming, everything they are helping. So here also we have to have a package like that. Is anybody able to talk to Dr. Manoj?
Sir, ma'am, I told him to join from another device.
But
He
what
said
is the
he's
problem?
he's telling I'm not aware that I'm not audible, so I told login from some other device. Now he has joined from other device, ma'am. He's in the waiting room. Sandeep, make him co-host. Dr. Manoj has joined from other device.
Am I audible? Oh,
Yes,
Sir.
but we have a echo now. Thank you. Please continue.
okay, madam. First of all, I would say very much thank you to you to give me this opportunity to speak in this conference. Second, actually, madam, I'm very much mesmerized by the kind of the energy and the the leadership that you are having in conducting this workshop as well as this conference. And the third thing is that you have given a very good overview so that my job has become really very easy. I hope I am audible to everybody.
Yes, finally, yes.
Yes, sir.
Okay. The next slide, please. So I will be covering my topic under these headings: substance use disorder, what is the current scenario, the phases of treatment, options of the long-term recovery, and collaborative models of recovery, and finally the conclusion. Next slide, please. So if we talk about the substance use disorder scenario, uh, the worldwide WHO has estimated that approximately 35. My slide is on. The WHO has estimated that approximately 35 million people worldwide suffer from substance use disorder. And according to the World Drug Report 2023 by the United Nations Office on Drugs and Crime, over 296 million people globally use drugs in 2021. And as per the National Survey on Extent and Pattern of Substance Use in India, conducted by Ministry through the National Drug Dependence Treatment Center AIMS during the 2018, the data reveals that more than 32 million people are having used the drugs. So when we say that 32 million people have used the drugs, so then automatically one thing is very clear to all of us that one man army cannot able to treat this whole problem. We need more number of working hands and whatever the resources which are available across us, we should have to be utilizing this. So now coming to the phases of treatment, there are few phases of treatment. The first phase of the treatment is detoxification. So in the detoxification phase, primarily it can be done on the OPD basis, it can be done in the inpatient basis, and the primary mode of treatment for this phase is primarily pharmacological. Next slide, please. So detox alone is not adequate treatment for the addictive disorders. So we have to understand that just by merely keeping a patient for 10-15 days in a hospital and detoxifying it will not be the proper solution for such patients. We have to go beyond that one. Next slide, please. So the second phase is the relapse prevention. So in the relapse prevention, there are pharmacological options, but unfortunately, these pharmacological options like anti-craving drugs is not available for each and every type of substances. We have anti-craving agents for alcohol. We have anti-craving agents for certain other substances, but not for every substance we are having a pharmacological options. And then similarly, the maintenance drug. Maintenance drug, when we say we have options like methadone, we have options like buprenorphine, we have options like nicotine gum. So similarly, when a person has decided that I cannot able to live without this substance, so it is better to give me some medication so that I keep on taking it without causing any harm to the society and the self. Then in those cases, we might be using this maintenance drug. So these maintenance drugs is also not an option available for each and every patient. So we have to rely heavily on the non-pharmacological options in the relapse prevention. Next slide, please. So when we talk about the non-pharmacological intervention, it is important that we understand the clinical condition of the patient. And there are certain models has been given for assessment of the stage of motivation in the person. So there are, 6 stages of motivation, which has been given by the Prochaska and De Clemente. So pre-contemplation, contemplation, preparation, action, maintenance, and relapse. So depending on the which stage of the motivation the patient is in, we will try to take the patient to the next level of motivation by doing non-pharmacological intervention. Next slide, please. So when we say the relapse prevention, broadly, it is conceived as a cognitive behavior therapy with a focus on the maintenance stage of the addictive behavior. It has a main two goals: to prevent the occurrence of initial lapse after a commitment of changes has been made, and to prevent any further lapse that occurs from escalating into a full blown relapse. Next slide, please. So the goals of the relapse prevention are few. Like we have to reduce the use of the drug. I mean, say for example, we might be talking about the controlled use. So, or second is maybe the limiting the number of users and the types of the substance used. So we have a very specific goal for the relapse prevention. Next slide, please. And so as earlier mentioned, the relapse is the worsening of the symptoms or the recurrence of the unhealthy behavior, such as avoidance or the substance use after a period of improvement. So relapse is not all or none. There are few stages of relapse. So there are stages like emotional relapse, there is a mental relapse, and then finally comes the physical relapse. So when a person is going to relapse, there are the 3 stages. First is the emotional, second is mental, and third is the physical relapse. So what are the signs and symptoms of emotional relapse? Next slide, please. So in the stages of emotional relapse, the person might be having an anxiety, intolerance, anger, defensiveness, mood swings. So these are some of those emotional symptoms which might be present, which is triggering the person to think about taking the substance. So in this stage, the person is only thinking about taking the drug, but not actually has been, started consuming that substance. Next slide, please. Now, some of the other symptoms in the emotional relapse could be isolation, not able to help, not asking for help, not going to meetings, poor eating habits, or poor sleep habits. So all these symptoms of, these are the symptoms which can be identified in the emotional stage of relapse prevention. And if we will not act on this stage, it is likely to go into a mental relapse. Next slide, please. So when we say the mental relapse, the patient there is a war is going on in the mind of the person to take or not to take the substance. So the signs and symptoms of the mental relapse are thinking about the people, places, or the things the person used to, glamorizing the past experiences of use of drug, lying, hanging out with the old friend, those who are using the substance, those who are using the substances, fantasizing about the using the substances, thinking about relapsing, and planning the relapse around the people. Around the other people's schedule. So these are the some of the signs and symptoms of mental relapse. Next slide, please. Then finally comes the physical relapse when the person is not able to control and he actually starts taking the substance. So this is when the person has started taking the substance. This is called the physical relapse. Next slide, please. Next please. Next, please. Next, please. So there is a trigger. Trigger will lead to the thought. Thought will lead to the craving, and craving is finally manifest in the form of the use of the drugs. Next slide, please. So this is how the person, which was initially a trigger, which is maybe an event, it may be something about the person is thinking, and gradually it is such a slippery progress that the magnitude of those trigger will become so overwhelming that the person is not able to control and finally starts using the substances. Next slide, please. So when we talk about the relapse is a very limited terminology. So the more correct terminology which we have to use is a recovery. And when we say recovery, it is a broader perspective. So it is a process of change that involves improving the health and the well-being, living a self-directed life, and reaching one's full potential. Recovery can involve the remission. Remission means stopping or reducing the substance use to a safe level. But beyond this one, there is a need for lifestyle changes, adopting the positive changes and the values into a daily life, managing the negative feelings. So handling the negative feelings without using the substances, living a contributive life, participating in the society through the meaningful activities, building the social support, developing the relationship with the friends and the family, and improving the mental health, experiencing the enhancement in the mental health and the quality of life. So there are various domains in which the person will have to work so that the recovery is possible. Merely just stopping the substance will ultimately lead to the relapse more commonly. So we have to use the broader perspective of recovery. And when we say recovery, there are multiple areas of the life has to be changing, in which the multiple stakeholders can be involved, so that the recovery becomes better in the person. Next slide, please. So when we say the recovery, the vital components of recovery include support of the family and the friends, 12-step meeting and sponsorships, individual group and family therapy, proper rest, moderate exercise and nutrition, avoidance of slippery situations such as bars, medical supervision, and psychiatric support. So these are various components of recovery. Next slide, please. So recovery is not a static condition, it is an ongoing process. So we cannot able to say the person has stopped taking the substance, he has recovered. So it is an ongoing process because we know that many people, because of the various conditions, are likely to get relapse. So it is a process which has to be followed over the years, and it is not just merely an absence of drugs or after the detoxification. We can consider that it is the person has recovered. So relapse occurs when the attitudes and behavior revert to the ones similar to those exhibited when the person was actively using the drugs or alcohol. Next slide, please. So recovery in the substance use disorder is a structured plan for living that builds a foundation upon which the patient can function effectively and comfortably. This foundation creates the ability for the person in the recovery and to avoid circumstances in which they might be vulnerable. Recovery requires the changes in the attitudes, values, lifestyles, and behavior. Next slide, please. Although the relapse can occur at any time, it is more likely to occur in the recovery process. So it is important that it is important to understand that at this stage, the habits and the attitude needed for the continued sobriety, skills required to replace the substance use, and the relations with the positive peers are not firmly entrenched. That means when the person is not having these areas, work has not been done in these areas, the person is likely to get relapsed. Next slide, please. So relapse is a common and recovery is a mirage. So when we talking about the substance use disorder, this dictum has to be remembered because we have seen over the whether it is a West or it is in Asian countries, this is a similar kind of the problem that we have encountered. That relapse is very common and the recovery is a mirage. Though the recovery, though the Though the recovery is difficult to achieve but not impossible, and a collaborative approach is required to achieve this difficult milestone. Next slide, please. Collaboration is crucial in addressing the substance use disorder because effective treatment often requires a coordinated effort from a variety of professionals, organization, and support system. Professionals from the different backgrounds can address the complex physical, psychological, and social aspect of substance use, ultimately leading to the better outcome for the individuals. Next slide, please. Now there are, who are the people who can be integrated in management of this management of the patient with the substance use disorder. So these teams include often the addiction specialists, psychiatrists, primary care physicians, social workers, counselors, and the case manager. Each professional brings the expertise that addresses the different aspects of the disorder, from medical detox to the long-term psychological support. Next slide, please. Then there are medical and behavioral health coordination. Because we know that substance use disorder often co-occurs with the mental health issues, which requires a close collaboration between addiction and the mental health professionals. By coordinating care, they can develop the individualized treatment plan that simultaneously address both the mental health and the substance use, reducing the risk of relapse. Next slide, please. Then there is a family and the community support coordination is required. So family members, friends, and a community support network plays a vital role in the recovery process. Collaboration with a community-based organization, peer support groups, and the family education programs can help the person to sustain long-term recovery by providing the social support, accountability, and motivation. Next slide, please. Law enforcement and criminal justice partnerships. So programs like drug courts, diversion programs, and community corrections can be essential in providing the alternative pathways to rehabilitation instead of incarceration. So means putting the patient only in the hospitals or in the de-addiction centers is not the solution. So collaboration with these sectors help to reduce recidivism, offering individual access to treatment and community resources. So there are multiple areas. The law enforcement and criminal justice partnership is also required. Next slide, please. Now, public health and policy collaboration. There is a collaboration at the public health level, includes working with the policymakers, advocacy groups, and healthcare providers to increase the access to the treatment, harm reduction services, and preventive interventions. Policy changes can improve the access to the evidence-based treatment, reduce stigma, and promote the safer areas. Now, the data sharing and research partnership is also important. Because of this, we will be able to generate the data, and based on the data, we can able to plan for the uh, further policy making. Next slide, please. Now, technology and telehealth. In the areas where there is in-person treatment options are very limited, telehealth services can offer an effective way to reach the individual in the needs. Technology platforms and apps can connect patients with the counselors, support groups, and other resources. So this is also one of the very important tool which can help the person, those who are living in the remote area where the services are not available, they can able to take the help on phone, and this also provides the counseling services. So the government has run these programs free of cost, so the person can able to take the help for this. Next slide, please. Now coming to the various models of collaboration. So we have to understand that this, it is not one person army. We have to involve the social workers, the psychiatrists, with the various other professionals, family, then community level, then law enforcement agencies. So everybody will have to work collaboratively, so that we can able to achieve the ultimate goal of recovery in the substance use disorder. Now there are various models of collaboration has been given. So these models of collaboration is primarily practiced in the Western population, because over there we have seen there is a different model of the treatment is available. What happens is, in the Western population is, the person will go to the primary care physician, and the primary care physician, depending on the need, will refer the patient to the higher centers. Over here in the India, even if the same thing is happening, the person might go to the primary care physician. From there, he might go to the community health center or to the district hospital, and then finally to the tertiary care hospital. But what happens when the person comes to the tertiary care center? They will not go back to the primary care center. They will keep on coming to the tertiary care center and utilizing and putting the burden on the tertiary care hospitals. Whereas whereas in the Western population, the person will have go back to the community, and the treatment is provided at the community level to the person, and every services which is required in the management of that person is being taken care of by the case manager, which can be a nurse, which can be a social worker, which can be any community worker. So there are various models of collaboration which is primarily practiced in the Western population, but it can be implemented in India and the other South Asian countries also. Now, next slide, please. The first model is a multidisciplinary collaboration. Multidisciplinary collaboration means there are various specialities are working in the under the same roof. So the person might be having a need for the liver problem, person might be having a problem for the lungs problem. So there is a pulmonologist is available. There is a person who is dealing with a hepatobiliary surgeon is also available. A specialist is available for these, and all those specialists are working together for the welfare of the patient without having a communication with each other. So that's called multidisciplinary. Though the patient is getting the benefit of this all these discipline in under the same roof, but there is hardly any coordination between the because there is no dialogue between the various physicians. Next slide, please. Slightly better than the multidisciplinary is the interdisciplinary collaboration. So in the interdisciplinary collaboration, the professionals from the various fields will work together on the shared goals and coordinate their effect closely. So say for example, we have seen the general hospitals where there is a multiple specialties are present. Here there is an interdisciplinary collaboration is present, but maybe one or two departments are interacting and they are planning an overall better outcome of the patient. That's interdisciplinary collaboration. Next slide, please. Even better than this interdisciplinary is a transdisciplinary collaboration that we see in many of the psychiatric institutes where there is a clinical psychologist present, there is a psychiatric social worker is present, and the social workers are there, the nurses are there, where they might be because the patient, those who are suffering of substance use disorder, doesn't need to be treated in a very tight water compartments. The person from psychology can also do this counseling, the person from social worker can also do the counseling, psychiatrist would do the counseling, even the nursing member can do the counseling, and even the pharmacist can also be involved, so that everybody, the roles is not very watertight, and they can able to provide the services to the patient beyond their discipline. So the professional from the different fields collaborate so closely that the roles may overlap, and the team members can perform some functions outside of their traditional scope. So it doesn't mean that if a nurse has to only provide the nursing care, they can able to provide the counseling to the person well. Because if a patient needs the services at any point of time, the help should be available to the person at that time. It cannot be that you take an appointment, go over there, talk to the psychiatrist or talk to the clinical psychologist and take an appointment, which might be after 1 month or 2 months. So anybody can able to provide the help to the person, those who are in the need of the help at that point of time. So this is slightly better than the interdisciplinary or the multidisciplinary model. Next slide, please. Now there is an integrated care model. So mental health and substance use services are fully integrated with the primary care and other medical services. So this integrated care model will be, so person who is treating this patient, say for example, the person is being treated in a very rural area. So the primary care physician, they will be more comfortable with the primary care physician, and that primary care physician will be able to talk to the mental health specialist. He will be able to talk to the addiction specialist and should be able to provide that services to the patient at that level. So this should be the primary goal, that the person should be able to get every services through his primary care physician rather than coming to a tertiary care specialist, or maybe a higher level district level of and explain each and everything to the physicians again and again, which may be very much embarrassing, which may be very stigmatizing, that they will go to the different persons and then they'll talk about their problems, and they may not be able to communicate it properly. So which is very easier for a person to go to his local physician and talk to them, and then every services should be provided to the patient through this local physician. Next slide, please. Then patient-centered medical home. Here, there is a team-based care model focused on delivering comprehensive patient-centered care, where the patient needs drive the coordination of the care. Means whatever we decide about what is required for the patient, everything has to be customized and tailor-made for the need of the patient, and it should be provided to the patient at his home environment. Next slide, please. Then we have an accountable care organization. So it's a network of providers and facilities that collaboratively manage care for a defined patient population, focusing on the quality and the cost effectiveness. So means recently you might have heard there is a government of India has launched a program which is called Nasha Mukt Bharat Abhiyan. But in this Nasha Mukt Bharat Abhiyan, not every district of the India are being covered. They have identified the districts in which there is more substance use disorder is present, and in the all those districts where there's a more substance use is present, only in those areas this Nashamukht Bharat Abhiyan has been started. So ultimately the resources are being tailor-made to that district, and in that district there is a support is generated through the community health worker and other specialists, and the accountability has been fixed to make that area, that district free of substance. Next slide, please. Then there is a hub and spoke model. So there is a centralized hub provides a specialized service while the spokes extend care access in the regional or community-based setting. So means, say for example, if a person needs an management of a DT in a delirium tremens, it is required to be managed at a tertiary care center or maybe at a bigger center. But some of those services, which is say for example the counseling, that can be provided through the other mental health specialists or service delivery by the community workers, by the nurses, by everybody. Next slide, please. Then there is a collaborative care model. It's a structured approach in which the primary care providers work closely with the behavioral health specialists and case managers to treat the mental health and substance use condition. Next slide, please. Then there is a community-based collaboration. Here there is a partnership between the healthcare providers and a community organization that provides holistic support for people with a substance use disorder. Next slide, please. And there is a public-private partnership. Here there is a collaboration between the government entities, non-profit and private organization to pool the resources and provide the comprehensive services. Means in the countries like when there is more than 32 million people are using the drugs, it may not be possible for only the government to work. So whatever the resources which are available in the community, there can be some coordination can be possible so that we will be able to deliver the services to the person in the community level without putting each and every burden onto the tertiary care centers, and where the person might not be feel comfortable coming each and every time. So there's a more chances of the treatment gap is present. They may not be able to come, maybe because of the stigma, because of the availability of the resources, or maybe the time is not available. So this public-private partnership can play a major role in treatment of substance use disorder. Next slide, please. So the conclusion is the magnitude of substance use is massive globally across globe, and there is a huge treatment gap is present in the substance use disorder treatment. Relapse is a common phenomenon in substance use disorder. Collaborative work is necessary to improve the overall outcome in persons with substance use. Collaboration is required at various levels, and involvement of various stakeholders is key to recovery process. The models of collaboration which are tried in the West can also be implemented in the other countries, including India, to improve the long-term recovery in substance use disorder. That means we can able to work with a nutritionist, with physiotherapists, with yoga therapy, with nurses, with mental health professionals, with counselors. Everyone has to be involved and provide the services to the person there and then at the community level, rather than bringing each and everybody to the tertiary care center, which may not be able to cater to the needs of each and every patient, and ultimately the patient is lost. So, as the Sandhya madam has said in her presentation, that detoxification is not the only thing which a patient has to go through. A lot of changes which is possible only when all these professionals are being involved, and a long-term treatment plan is made to ensure the recovery in the substance disorder is possible. So with this, I say thank you to everyone for your patient listening, and if there is any clarification, I'm ready to answer those questions.
Thank you, Dr. Manoj, for enlightening everybody on the collaboration aspects. The most important thing here is, are we here to help somebody, or are we here to make somebody go back to the previous life? Now, there are two ways of looking at a patient. You want the patient to go back to the mainstream. You want patient to become responsible person. You want patient to be like me and you. Can I be a patient tomorrow? Can you be a patient tomorrow? What is your thinking about that? So just try to understand. So this is something like, if I do overeating, I will suffer from a lot of problems due to obesity. So it is something like that. So we are not disrespecting anybody who is obese because of overeating, but we are disrespecting this person because of physiology. This person happened to become dependent on a substance. So please look at the patient as if I can be patient tomorrow. I can develop any kind of dependence tomorrow. So how I would like people to help me to come back to my normal stream, go back to becoming a responsible person. So it's not the symptom, it's not the disorder, it's not a bad habit that we are treating, but we are working with the individual who needs our support. So it's called dancing with the patient. Whatever type of support required, we have to provide that. Because we want everybody to become responsible person. Responsible for themselves, responsible for their families, responsible for this country, responsible for mankind. So that is our goal when we are talking so much about this. Now I request Renju to please tell us how we are going for the group work. If anybody wants to ask anything, you can write in the chat box. We'll address your questions with the help of chat box. Because now we are going to give you group assignment. Please, can I have the slides, Renju, for group assignment?
Sandeep will project the slides, ma'am. Sandeep, please.
Or Surbala, can you share, please?
Ma'am, Sandeep is sharing now.
Sandeep is sharing. So all of you will go into different groups and you have different facilitators who are helping you. Whatever you have gained from the lecture in the morning, it is of no consequence if it is not used by you in this assignment. So we are giving you assignment so that you can utilize everything and add your own suggestions. You see, no lecture is enough to do anything for other person. Now it is your own thinking, your own experiences, your own thinking about various issues, which will bring this group work to a success. So let us see what you are going to do. You have to develop a proposal for model or framework for helping a particular type of problem that people have, how you will help them. Next, please.
Ma'am, can I?
Now, these are some of the cases and some of the facilitators which are given here. Accordingly, you will be given into the groups and these cases will be discussed. What we have to do is, for this particular person, you have to develop a framework and come back and present to us. Go to next. And go to next and go to next. Keep going. There are 5 groups. Keep going. So all of you know that you have facilitators to help you with this. Now they will be talking to you in the smaller groups. So we will be waiting for you in this main room. When you come back after doing this assignment, we will be listening to your presentations. So you have exactly 20 minutes to develop your framework and come back to us. 20 minutes we are waiting in the main room for all of you. Over to Ranju.
So I request all the delegates to see the WhatsApp group. There is link given for each one of you. So yesterday I have shared the entire group list, so you know which group you belongs to. So see that main group list and join in the concerned group Google Meet link, so that you can start your case group work. So the facilitators are there. They will be guiding you how to go ahead. So we have given case scenario for each group. So you have to develop a collaboration work plan. So group A facilitators, Sandeep, group A facilitators are Atul, RP Sharma and Miss Denny Mariam and Dr. Surbala. Group leaders are Miss Nigunj and Rashi Puri. Group B, next slide please. Group B facilitators are Dr. Kunjalata Gogoi, Miss Gurleen and Dr. Lakshmi. The group leaders are Miss Poonam and Richa Singh. Next slide. Group C facilitators are Dr. Jyoti Katwal, Dr. Padmini and Dr. Renju. Group leaders are Miss Pronita and Miss Cinderella. Next slide. Group D facilitators are Dr. Taslim and Miss Chitra Bora. The leaders are Miss Shamina and Miss Alia Hussain. Group E. Last group. Next slide. Group E facilitators are Miss Kirti Mohanan and Miss Sagrika. The group leaders are Miss Madhusmita and Miss Firdos. So I request all the group members to join the concerned group Google Meet link so that you can start your group work. All the best. So you'll be given 20 minutes for the group work. Afterwards, you have to come back to the main Zoom So I request, if you have two device, so keep login with the Zoom, and with the next other device you can join the Google Meet link, so that there will not be any problem. So all the best. Now we are starting with the group work.
See, the group Google link is also shared by Dr. Jyoti in the chat. All of you, please go through once again and please join in the respective groups, whichever group you belong.
So all the experts, I request you please remain login and please come back after 20 minutes, but remain login in this Zoom. Thank you.
Sandhya ma'am, I'll stop the live in the YouTube for the time being.
Yes. You can stop the YouTube for the time being.
Yes, ma'am.
Now we'll start the YouTube only at 2 o'clock.
Okay, ma'am.